So hemolytic anemia মধ্যে পড়ছে sickle cell thalassemia, sickle cell anemia, G6PD deficiency, hereditary spherocytosis, সব এগুলো these are part of hemolytic anemia. So what is your basic idea of thalassemia? Globin chain synthesis, very good. So is it a genetic cause or an acquired cause? Inherited. So this is inherited. So inherited, what does it do? What does it do? Yes, go ahead. Chromosome 16 and chromosome 11 সেখানে কি থাকে? So basically inherited mutations কি করাচ্ছে? Inherited mutations কি করাচ্ছে? They reduce either total inhibition or reduce synthesis of globin chains. Either there is total absence or there is reduced synthesis of globin chains. So ultimately কি হচ্ছে? Ultimately কি হচ্ছে? Abnormal hemoglobin synthesis. Right? So this is thalassemia. It's a genetic disease. It's a genetic disorder where there is inherited mutations which either reduce or totally terminate the synthesis of globin chains. So যদি globin chain synthesis affect হয়, if the synthesis of globin chains is affected, what is the ultimate result? There is either abnormal synthesis or reduced synthesis or no synthesis of hemoglobin. Right? তো আমাদের hemoglobinটা কিরকম থাকে? What is the structure of hemoglobin? What is the adult hemoglobin? What is the adult hemoglobin? So what is it? HbA. HbA তে কি আছে? Alpha 2, beta 2. Means a pair of alpha chain and a pair of beta chain. আমি একদম স্টোরির মতো বলার চেষ্টা করছি so that it becomes easy for you. Okay? Alpha chain is encoded by what? A pair of, come in, micro to, come in. A pair of alpha genes. Where it is located? Chromosome 16. And beta chains encoded by a single, not a pair, a single beta globin gene. Where it is located? Chromosome 11. Chromosome 11. Right? Globin is formed of alpha and beta chains. So depending on which chain is involved. If alpha chain is involved, we call it alpha-thalassemia. If beta chain is involved, it is called beta-thalassemia. Simple. Alpha chain involved only alpha-thalassemia, beta chain, beta-thalassemia. We are going to stick to beta-thalassemia, which is more important. Okay, and more common. Right? So, so now think clinically ki hote pare. What can happen clinically? There is abnormal hemoglobin formation or deficient hemoglobin formation. Deficient hemoglobin formation hole ki hote pare? Underhemoglobinized microcytic hypochromic RBCs. Underhemoglobinized microcytic hypochromic RBCs can be one of the consequences. But what gives rise to tissue hypoxia and hemolysis? So underhemoglobinized microcytic, here I have mentioned no, leading to anemia, tissue hypoxia and red cell hemolysis. So anemia keno hobe? Because of abnormal hemoglobin formation. Underhemoglobinized microcytic hypochromic red cells. These underhemoglobinized microcytic hypochromic red cells have reduced oxygen carrying capacity. Their oxygen carrying capacity is reduced, mitigated. This is the reason why enough oxygen will never be delivered to tissues. That is the reason why hypoxia develops. My next question is, why hemolysis? Why it is a hemolytic anemia? I have mentioned here hemolysis. Keno hemolysis hoy? Think. I'm telling you like a story. Jodi, if you remember these points na, thalassemia will be very easy for you. If you can remember these points, I'm just telling you like a story. Alpha chain, beta chain, alpha chain, normal hemoglobin, adult hemoglobin is HbA, formed of a pair of alpha chains and a pair of beta chains. If alpha chain is involved, whether there is reduced synthesis or total absent synthesis, tahale ki hocche? Alpha-thalassemia. The same goes for beta-thalassemia. Reduced synthesis or absent synthesis gives of beta chains gives rise to beta-thalassemia. So, clinically, ki hocche? This patients present with anemia, tissue hypoxia and hemolysis. Why there is anemia? Because of underhemoglobinized microcytic hypochromic red cells. Underhemoglobinized microcytic hypochromic red cells has reduced oxygen carrying capacity. Normal hemoglobin because they are deficient in chains, because they are abnormal, their capacity to carry oxygen and deliver it to tissues is cut down. That is the reason why we have tissue hypoxia. Right? Hemoglobin ki carry kore oxygen. Jodi hemoglobin abnormal thake, it will not be able to carry oxygen, so there will be hypoxia. Right? Why hemolysis? Huh? Yes, good. Why that happens? Good answer, but why that happens? Yes? So what has that to do with it, with hemolysis? What has that to do with phagocytosis? See, good try. A pair, mone rakhbe, alpha and beta chains, they are pairs, couples. Ekta jodi noshto hoye jay, arekta ki hobe? That coupling will go. So, dhoro, jodi ei rokom thake situation ta, alpha 2, beta 2, right? One of them is gone. So if this is the red cell, for example, this coupling is gone. So normally alpha 2, beta 2 dhora eibhabe exist korche. This is normal. Now this thing is gone. That coupling is gone. Pairing is gone. This alpha 2 will form aggregates. This alpha 2 will form aggregate just below the cell membrane. This alpha 2 chain will form insoluble aggregates just below the red cell membrane. So, such abnormal red cells, such red cells with abnormal hemoglobin will flat out undergo apoptosis inside the bone marrow. Got my point? Alpha and beta are couples. Beta is gone. So alpha ki hoye gelo? Uncoupled. Single hoye gelo. Not compatible with life. So this alpha chain without beta will go and form insoluble aggregates just below the cell membrane. Ekhane alpha chain will form insoluble aggregates below the red cell membrane, just next to the red cell membrane. So these cells die by 75 to 80% of these cells die via apoptosis in the bone marrow itself. 70 to 75% die by apoptosis. Rest 20 to 25% who manage to escape in the peripheral circulation. PC means peripheral circulation, right? Bone marrow theke kothay asbe eta? Peripheral circulation, blood. This peripheral, as you say, this abnormal red cells in the peripheral circulation will undergo what? Phagocytosis. Where? In the spleen. Right? This abnormal red cells bearing alpha 2 inclusions, if they manage to escape from the bone marrow into the peripheral circulation, they will undergo what? Phagocytosis by splenic macrophages. And this is the reason why patient with thalassemia has splenomegaly. There will be splenic sequestrations of RBC and phagocytic hyperplasia. Okay, I'm coming to that. This is the reason why you have, this is intravascular hemolysis, jokhon bone marrow hote hocche, that is intravascular hemolysis. When it happens in the peripheral blood, this is extravascular hemolysis. So ultimately, this gives rise to what is known as ineffective erythropoiesis. So this is thalassemia basically. Clear? Should I explain again? Should I explain again? Huh? Just remember these points. It will become very easy for you. Basic. This is the core. What I am speaking right now is the core. So please pay attention. If this gets into your head, thalassemia will become a cakewalk. Hemoglobin, adult hemoglobin is HbA formed of a pair of alpha chain and a pair of beta chains. If there is a problem in the alpha chain, it is called alpha-thalassemia. Jodi, the problem, that pathology lies in the beta chain, it is beta-thalassemia. So let's concentrate on beta-thalassemia. Beta-thalassemia, তিনটে জিনিস আমাদের মাথায় রাখতে হবে. One is anemia, right? The other is tissue hypoxia and hemolysis. So why there is anemia and tissue hypoxia? How does that happen? So normal hemoglobin jodi na hoy, automatically that will be underhemoglobinized. It's easy for you, that it doesn't need any explanation. Underhemoglobinized microcytic hypochromic red cells. Hemoglobin er through te ki jay? What travels through hemoglobin? Normal hemoglobin, oxygen. Jodi underhemoglobinized microcytic hypochromic red cells jodi hoy, the capacity to carry oxygen is cut down. So these hemoglobins cannot carry enough oxygen to the tissues, depriving it of oxygen, giving rise to what? Tissue hypoxia. Is that clear? And there is hemolysis. So how hemolysis occurs? Alpha 2, beta 2 are a couple, a pair. Tar moddhe se beta 2 is gone. So alpha 2 now has become unpaired. Alpha 2 remains in an unpaired form. The pairing is gone. So unpaired alpha 2 is not compatible with life. Such kind of red cells are not compatible with life. So what happens is alpha 2 goes and accumulates just below the red cell membrane. So the body senses it. The body senses it. This type of red cells are not compatible with life. So 70 to 75% of such red cells die inside the bone marrow itself via the process of apoptosis, giving rise to intravascular hemolysis. Whereas 20 to 25% of those abnormal RBCs with alpha inclusions, which manage to escape the bone marrow into the peripheral circulation, are finally sequestered by macrophages in the spleen, giving rise to intravascular hemolysis. So there is giving rise to extravascular hemolysis. And because of this splenic sequestration and phagocytic hyperplasia, there is splenomegaly. Splenomegaly is a characteristic feature of thalassemia. Eta asha kori jano. Probably you have heard of it. I'll be coming to that, but this is the reason. Okay. So these are the cardinal features. These are the cardinal features. So if you remember these points, thalassemia will become very easy for you. Rest won't be very tough. Okay. So this is the normal hemoglobin structure which I have mentioned. Maximum is HbA. Other than that, we have little of HbA2 and HbF, fetal hemoglobin. Okay. So normal hemoglobin is HbA. So how do you classify hemoglobin? How do you classify thalassemia? Based on the type of globin chain defect. I've just explained alpha or beta. I've just explained this to you. And the other is based on clinical severity, whether it's major, whether it's intermediate, or whether it's minor, right? So these are the two classifications. Remember that one is based on the defective globin chain, whether the alpha chain is involved or the beta chain is involved. Alpha chain involved, we call it alpha-thalassemia. Beta chain involved, we call it beta-thalassemia. So that is the genetic part, and based on the clinical severity, whether it's major, whether it's intermediate or minor. Okay. So coming to the molecular pathogenesis, just remember the names. Point mutation is at the core of all the pathology. Sequencing of the beta-thalassemia gene has found out almost 100 different mutations. Most of them are point mutations. So these point mutations, they can be again classified into splicing mutations. Just remember the name, it's not important. Splicing mutations is mostly the cause of beta-0 thalassemia. Beta-0 and sometimes a little of beta-plus thalassemia. Then there is promoter region mutations, which reduces the transcription by 75 to 80%. Ami agabar bolchi, if you can remember the name, it's fine. They predominantly give rise to beta-plus mutations, and the last one is chain terminator. There is beta-0 thalassemia. So I'm coming to what is beta-0 thalassemia and what is beta-plus thalassemia. Okay, so just remember the name. Predominantly it's point mutations. Point mutations and what is splicing, point promoter region mutations and chain terminator mutations. So this is the genetic classification. So beta-thalassemia major. Now beta gene take jodi amra, if we consider beta gene, if we consider beta gene, for example, beta gene is normal. Very much compatible with life. Very much compatible with life. Normal. Beta-0 mane ki? No beta chain. Absolutely no beta chain. Nil. There is no beta chain synthesis. Beta-0. What is beta plus? Sorry. What is beta plus? Huh? Reduced. Reduced. Both are abnormal. Both are incompatible with life. So, for survival, they need blood transfusion. Clear? Beta is normal, very much compatible with life. Beta-0 and beta-plus are abnormal, incompatible with life, and they need blood transfusion. Such patients need blood transfusion for survival. Okay. Beta-0 means there is total absence of beta-globin chain synthesis, total absence, 0. Beta-plus means reduced but detectable beta chain synthesis. But both are incompatible with life, and to survive, the patient must be transfused with blood. Correct? So, beta-thalassemia is a classification. Beta-thalassemia major, beta-thalassemia intermediate, beta-thalassemia minor. So what is beta-thalassemia major? Major mane ki? Predominant. So tar gene ta kirokom hote pare? This question is important. Homozygous. Homozygous. Beta-0 ভীষণ খারাপ। Beta-0 কোনো beta chain নেই তার মধ্যে। Beta-0 beta-plus or beta-plus reduced but detectable, still incompatible with life, or beta-0 beta-plus means both beta genes are abnormal. Beta-0 and beta-plus means both beta genes are abnormal. So it can be either beta-0 beta-plus or beta-0 beta-plus. মানে দুটো জিনই কিন্তু both the beta genes are abnormal. নিচে আছে, so such patients without blood cannot survive, require severe blood transfusions. Then comes beta-thalassemia intermediate. আগে আমি beta-thalassemia minor এ যাচ্ছি. Beta-thalassemia minor very much compatible with life. Okay, beta thalassemia minor কি হবে? Heterozygous. কেন heterozygous? One beta chain will be abnormal. Either it can be beta, one normal beta chain, one abnormal beta chain. It can be beta or beta 0 or beta plus. So that is heterozygous. They are heterozygous. They are compatible with life. So দুটো extreme হয়ে গেল. In between comes the beta-thalassemia intermedia. In between comes the beta-thalassemia intermedia. তাহলে ওদের কি হতে পারে? জিনোটাইপটা beta 0 beta plus which is homozygous, and beta 0 beta or beta plus beta. So beta 0 beta plus beta, that is okay, better. Their prognosis is far better because they have one normal beta gene. Okay, so this please remember this classification. This is important. So if you know beta 0 means total absence of beta globin chain, and beta plus means reduced but detectable beta globin synthesis, and beta means normal, it won't be difficult for you to understand, or it won't be difficult for you to put in words if this question comes, the molecular genetics of beta this. So remember the mutations, just say about point mutations predominant, out of that splicing mutations, chain promoter region mutations, and chain terminator mutations, then come to this genetic classification of beta thalassemia. Beta thalassemia major, তার gene dosage টা কিরকম হবে? Major means homozygous, পুরো abnormal হবে, right? Both the beta genes are abnormal. Beta thalassemia intermedia হবে heterozygous, one beta chain normal, one beta chain abnormal, and in between you have the variable category. It can be homozygous and heterozygous, depends. The patient can have both abnormal beta chains or one normal beta chain and one abnormal beta chain. Okay, is that clear? Clear? You have to go and read. You have to go and read. So how does it affect? One is accumulation of free alpha chains. আমি explain করেছি how hemolysis occurs. Free alpha chains form insoluble aggregates just below the red cell membrane, and such kind of red cells, either they undergo apoptosis in the bone marrow, giving rise to intravascular hemolysis, or if they manage to escape the bone marrow into the peripheral circulation, they are sequestered by splenic macrophages and they undergo extravascular hemolysis, right? So accumulation of free alpha chains, both I have mentioned. Bone changes, extramedullary hematopoiesis, and iron overload. I'm coming to those points. So what bone changes occur? Think now, what bone changes can occur? Bone changes can হবে adulte, which is the site of erythropoiesis, flat bones, long bones, femur, tibia, right? So normally we are normal, fortunately enough we are normal. আমাদের মধ্যে flat bones এ হচ্ছে, sorry, long bones এর মধ্যে হচ্ছে. In case of anemia, in case of thalassemia কি হচ্ছে? thalassemia তে কি হচ্ছে? anemia হচ্ছে. There is hemolysis হচ্ছে. hemolysis হচ্ছে মানে কি? The patient has to survive. The body কি করবে? nature কি করবে? They will try to save the patient. In order to save the patient, যে পেশেন্টের এত hemolysis হচ্ছে, these are এই যে এক্সাম্পল গুলো দিচ্ছি, these are all about thalassemia major, not intermediate বা minor, not minor, thalassemia major এর এগুলো. হ্যাঁ, প্রত্যেকটা ক্লিনিক্যাল ফিচার্স অ্যাবাউট বিটা থ্যালাসেমিয়া মেজর. তো বিটা থ্যালাসেমিয়া মেজরে কি হতে পারে? এরিথ্রোপয়েসিস কি হবে? when there is hemolysis, the body will, there will be a erythropoietic drive. There will be a erythropoietic drive. The body will try, the body has to compensate. It has to produce more RBCs. It has to produce more red cells, because red cells are either dying, the red cells are dying, or there is ineffective RBC form, ineffective erythropoiesis, whatever. The body has to cope up with the situation. তুমি যদি সারা বছর না পড়ে থাকো, তোমার 6 ঘন্টায় হবে না. You have to study for 18 hours, 19 hours. You're studying, going on. Someone, not you. Whoever it may be. আমি আমার সিচুয়েশনই ভাবছি when I was an undergraduate student. So আমাদের বডিরও সেই সিচুয়েশন. I haven't studied enough. I have 70% of the syllabus to be covered, so I keep on studying the entire day, entire night. Body row, RBC bhenge jacche, RBC is being hemolyzed. The body has to provide more RBCs. So bone marrow, the long bone marrow, the marrow inside the long bone is not enough. So ki hocche, other bones like the flat bones, pelvis, ribs, skull, sternum, these are the sites where RBC starts to be produced. এই সব ফ্ল্যাট বোনসে কিন্তু ইয়াং এজে হয়, মনে রাখবে, রাইট? অ্যাডাল্টে হয় না, কিন্তু এখানে কিন্তু আবার ওখানে RBC starts to form because of the extra erythropoietic drive. Because of the extra erythropoietic drive. So what can happen then? প্রচুর RBC production হচ্ছে বোনের মধ্যে. At some point of time, it will break the bone. It will lift the cortex. It will lift the cortex. Right? হতে হতে আর কত দিতে পারবে? The bone will ultimately break. It will lift the cortex, giving rise to various bony changes. One of the most important is that change takes place in the skull, known as crew-cut appearance. Crew-cut appearance. Because of reactive bone, jodi fete jay tale ki hobe? There will be reactive bone formation. It will, in the skull, it will give rise to what is known as crew-cut appearance. Other than bones, it can also be seen in soft tissues like spleen, liver, pelvis, giving rise to extra osseous masses. Giving rise to extra osseous masses. So I have told you. So you now is it clear what the bone changes is? Okay. Okay. One more thing. Jodi ekhane dekho, bone changes I have explained. Extramedullary hemopoiesis I have explained. Iron overload. Normally, there is a protein in the body called hepcidin. Hepcidin. Have you heard of hepcidin? Hepcidin is a negative regulator of iron. Hepcidin is a negative regulator of iron. It inhibits iron absorption. Now, there is, what happens is, in thalassemia patients, levels of hepcidin becomes low. Levels of hepcidin becomes low. That is one point. And second, these patients, these thalassemia major patients, have to be transfused with blood. Have to be transfused with blood. So blood e ki ache? Iron ache. Iron is getting accumulated in the blood. On one hand, there is iron accumulation in the body. On the other hand, there is negative regulation of hepcidin. There is down regulation of hepcidin. Hepcidin inhibits iron absorption. So if hepcidin levels falls in thalassemia patients, and thalassemia patients are given blood, and blood e ki ache? Iron ache. So obviously there is iron overload. Got my point? There is iron overload. So this iron, because of iron overload, the iron gets accumulated in various parenchymal organs like the heart, liver, spleen, kidney, giving rise to what is known as hemochromatosis and hemosiderosis. Hemochromatosis and hemosiderosis. Okay. So this is this kalami aschi. So this particular picture explains the entire pathology. This particular picture, this is given in Robbins, and this explains the entire pathology step by step. All the pathology, all the entire pathogenesis is explained here, and this is exactly which I told you. I don't need to see this and tell you. I have told you. If you want, you can take this. This is given in Robbins, or if you want, you can take this PowerPoint and you have to tally. I am telling you like a story. Prottekta step mathay rakhte hobe. Why there is, what bony changes happens, why there is iron overload. Iron overload jodi hoy, what can be the what will be the manifestations like hemochromatosis and hemosiderosis, the side effects of iron overload, or the side effects of blood transfusion in these patients. All these things you have to remember. Okay. Bone changes are by far, and iron overload, these are by far the most important. Okay. The clinical features, these patients are asymptomatic at birth, manifests after 6 to 9 months. Why? Because of HbF. 6 থেকে 9 months এর মধ্যে hemoglobin F ache, fetal hemoglobin. This fetal hemoglobin has an excellent oxygen carrying capacity, so even if the patients have some abnormality, chain defects, it is not manifested. Because why? The patient has hemoglobin F and HbF does the work. They carry oxygen. After 6 to 9 months, okay, 3 months whatever it may be, it should be up to 6 to 9 months, whatever. After that particular period, when HbF falls, the patient starts showing signs and symptoms. Okay, because hemoglobin F is down now, hemoglobin F er kaaj shesh. Now hemoglobin A, HbA, the adult hemoglobin should take over, but adult hemoglobin is absent. Adult hemoglobin is abnormal. So this patient starts to manifest after a few months when HbF declines. So what are the features? Like anemia, failure to thrive, poor feeding, and একটা জিনিস মনে রাখবে, these patients, they become excuse me, they become very cachexic. They become very cachexic because this extra erythropoietic drive, this abnormal erythroid precursor cells, they steal nutrients from other cells, making the person cachectic. So that is the reason why there is failure to thrive. So there is anemia, failure to thrive, poor feeding, intermittent infection, protuberant abdomen, etc., etc. These are all the features. If you can remember, fine. If you don't remember, no issues. Okay. Bony changes. Bony changes not only skull e dekha jay, but metacarpals, metatarsals eও দেখা যাচ্ছে. Okay. But remember this hair on end appearance. In metacarpals, metatarsals, হাতে পায়ে এগুলো হচ্ছে mosaic pattern appearance বলা হচ্ছে. Leave that, but remember this point, this thing, this is called hair on end appearance or crew cut appearance, mostly seen in the skull. It is because of what? Because of fracture. Because the expanding erythroid mass, they lift the pericortex and periosteum, resulting in new bone formation. And this is known as crew cut appearance or hair on end appearance, and this is predominantly seen in the skull. Okay. So bony changes, remember that bony changes. Then coming to growth and development, short stature, large head, okay, delayed puberty, and then endocrine function abnormalities. So these are all because of excessive iron overload. These are all because of excessive diabetes mellitus. That diabetes mellitus can be a dreaded complication. Why? Because the beta cells of islet, because again that iron gets accumulated in the pancreas, which I've just mentioned, and they destroy the beta cells of islets of Langerhans. So no insulin is secreted. That is why these patients get diabetes mellitus. Growth hormone deficiency, hypothyroidism, hypoparathyroidism, diabetes, all because of parenchymal iron deposition in these organs. Clear? Coming to lab evaluation, this is important. Laboratory evaluation is actually very important. Complete blood count. Complete blood count er moddhe peripheral blood smear tao pore jay. So hemoglobin will be reduced. Red cell indices, MCV, MCH will be low. MCV, MCH will be low. Okay. Anisopoikilocytosis means what? Variation in shape and size. Variation in shape and size. Anisopoikilocytosis. Excuse me. With microcytic hypochromic red cells, target cells. How does target cell look like? Can anyone explain? Center একটা red spot. What is that red spot? What do you mean by red spot, man? Hemoglobin accumulates in the center with a paler, মাঝখানটা pale, and then periphery again there is hemoglobin formation, as if at a dirt দেখিছো, dirt ছড়ে, bullseye বলি আমরা, bullseye, হ্যাঁ, ওই ডার্টের মতো একটা, ওই ডার্ট খেলা হয় না ওরকম, there is a target, সেন্টারে একটা টার্গেট থাকে, আমরা ডার্ট ছুড়ি, So these are called target cells because the hemoglobin appears right in the center. Then you get NRBCs, nucleated RBCs. What are nucleated RBCs? Normal RBC is biconvex because they don't have any nucleus. Kintu ekhane ki hocche? Abnormal RBCs are spilled into circulation. So you get NRBCs, normoblasts, nucleated RBCs. Okay, basophilic stippling. Basophilic stippling ki rokom jano? So আমি একে দেখিয়ে দিচ্ছি target cells. Target cells are like this because hemoglobin appears in the center. Basophilic stippling এইরকম ভাবে হবে because of iron accumulation. Because of iron accumulation, that is called basophilic stippling. Teardrop cells. চোখে জলের মতো teardrop cells. So microcytic hypochromic RBCs and all this microcytic hypochromic RBCs means change in shape, change in size, and teardrop cells, target cells, basophilic stippling, they're all change in shape. So change in size and change in shape, a combination of change in size and shape give rise to what is known as anisopoikilocytosis. শুধু যদি microcytic hypochromic RBC থাকতো আমরা কি বলতাম? Anisocytosis, change in size. But since shape change হচ্ছে teardrop cell, target cell, basophilic stippling, we call it anisopoikilocytosis. Okay, change in size and shape. Then these alpha chain aggregates can be demonstrated by supravital stain with methyl violet using phase contrast microscopy. Just remember this point. We have to look for the iron status. Shop barbe, serum ferritin, transferrin saturation, everything will increase because of iron overload. TIBC, total iron binding capacity, obviously will be reduced. They will come down. Right? Bone marrow te erythroid hypoplasia. If you look into the erythroid series, there will be erythroid hypoplasia. Megakaryocytes and myelocytes, myelopoiesis and megakaryopoiesis means WBC and platelet lineage, they remain normal. So these are the target cells, also known as scotocytes, teardrop cells, right? These are basophilic stippling. ঠিক এই ছবিটা যেরকম এঁকেছি মাঝখানে নিউক্লিয়াস টাকেনি যদিও. These are all iron accumulation. এই যে ডট ডট গুলো দেখতে পাচ্ছ, ডট 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 গুলো, these are all iron accumulation. And this is a NRBC. Look at these RBCs. এটা obviously thalassemia patient থেকে না, আপনি just normal NRBC দেখিয়েছি. What cell is this? That's a neutrophil. These are RBCs which don't have nucleus. They'll see this RBC, particular RBC which has a nucleus. So that is a NRBC. That's how it looks like. Okay. Just remember the name. Just remember the name. Kleehorst test, acid elution test. Cells with HbF are well stained, whereas cells with HbA, they are not stained, giving rise to ghost cells, giving rise to what is known as ghost cells. Okay. Hemoglobin electrophoresis, this is important. Hemoglobin electrophoresis is important. Hemoglobin electrophoresis is a normal pattern. There is HbA, increased HbA, whereas in beta-thalassemia, HbA is reduced. In beta-thalassemia, HbA will be reduced. HbF bere jabe. Right? Isn't it easy? HbF, so just look at this picture. HbA, in normal hemoglobin, HbA is normal, whereas in beta-thalassemia, HbA2 is reduced. HbA is reduced. Okay. So I think this ends the topic over here. Nothing much. So remember this lab evaluation. Write the complete blood CBC, complete blood count. Then it's supravital stains, iron status, bone marrow, Kleehorst test, and finally go to hemoglobin electrophoresis. In hemoglobin electrophoresis, 1 minute. In hemoglobin electrophoresis, in normal pattern, you will see increased HbA, which is the normal pattern, whereas in beta-thalassemia, HbA will be reduced.